about 12.5K in. And yeah, man, it's a good day.
When 47-year-old Sachin Latti ran across Canada this summer, he did so for a reason: to raise attention and funds for mental health services.
It's not too hot. It's a bit sunny. A little bit of clouds. So far, so good.
He suffered his own breakdown 5 years ago. And on his long trek, he says he met many Canadians who told him they are hurting too.
Urgent. Like, people are taking their lives. How urgent can it get? People are committing suicide. And people are struggling significantly. People are on the street. I hadn't seen this much homelessness ever.
On this episode, new data showing that 2 in 5 Canadians say they aren't getting any or enough mental health care to improve their lives.
In 2024, about 41% of adults with a diagnosed mental health condition said that their care needs were only partially met or completely unmet.
That's Cheryl Chui, Director of Health System Analytics for the Canadian Institute for Health Information, who talks about this new data, including wait times for counseling and disconnects between hospital care and follow-up in the community. It's new information because of a new deal between Ottawa and the provinces and territories in 2022 that offered targeted funding, in this case for mental health care, in return for more data on how those tax dollars are being used to help improve care. And we'll highlight one example of innovation that has cut hospital readmissions for mental illness and addiction by 400%.
We're very proud of the data, and people don't want to come to the emergency department. They don't want to come back to hospital. They want to get the help. And so doing something that I know is having an impact is incredibly important.
Welcome to the Canadian Institute for Health Information podcast. I'm Avis Favaro. A note, the opinions expressed here don't necessarily reflect those of CIHI, but it is an open discussion about new information and new hope that will track whether Canadians get the mental health support they desperately want and need. And now, joining us from Toronto, Cheryl Chui. Welcome, Cheryl.
Thank you for having me.
Now, let's start with the significance of this report. The data that you're getting is a little bit different and newer than CIHI has ever presented. Can you explain why?
So it's really a pleasure to be able to present some of these new results, and it's the first time we're able to measure some of this. And how we came to select these indicators was through a collaborative process that was led by CIHI, working with the federal, provincial, and territorial government and people with lived and living experience. And so what we've been doing over the last 2 years since this funding commitment was announced in 2023 has been to develop comparable and reliable data to measure these different aspects of mental health and substance use care.
And just to underscore, this is a new formula that we're highlighting because normally health transfers from Ottawa have no strings attached. Provinces and territories don't have to say where the health transfers go or what the outcomes are. But in this case, these targeted funds, in this case for mental health, came with a request. We want to see the data on how it's used and the outcomes, right?
Yes, that's right. We're actually able to now see across the country where there are improvements being made, but also where there are gaps that still need to be filled.
So that's important because it gives us a new picture that we've never seen before of how healthcare dollars are working.
Yes, that's right. And although it does take time for some of these changes to be seen in the data, this is a great place to start, to have this first baseline measure.
Why haven't you been able to collect this data before?
I mean, I think that for mental health and substance use care in particular, much of the care happens in the community. So as you can imagine, this takes a lot of collaboration, a lot of involvement from many different individuals across the country, which is why it's so great that we're able to present some of this information for the first time.
Let's start at the beginning. What did you find in terms of the number of Canadians who say they are not getting the mental health support that they need?
So this is data that we obtained from our data partner Statistics Canada, who conducted a national survey. And what they found was that in 2024, about 41% of adults, so this is individuals 18 and over with a diagnosed mental health condition, said that their care needs were only partially met or completely unmet. When we also start to break the numbers down a little bit, we see that it's actually unmet needs were highest among young adults.
And unmet needs means what? They can't get counseling
Or medication or other supports and it really depends on the condition, but this is their self-reported perception that their needs were not completely met.
And why is self-reporting important?
It's the perception and the experience of the individual who has the mental health condition that can really tell us about what is their experience of the healthcare system and the care that they're receiving or not receiving, and where are those gaps.
What are the consequences of all this unmet mental health needs?
So it could lead to a worsening or progression of their conditions. And in some cases, it might mean that they might require hospitalization.
Was there also a gender gap?
We did see a gender gap among children and youth, with 40% of girls who reported unmet needs compared to 32% of boys.
Interesting. So the girls are saying they need more help than they're getting.
Yes, and this is something that I think is quite an important thing to keep in mind. Not all of the care is covered by our provincial and territorial health systems in Canada. And so there are maybe additional barriers that individuals can face when seeking mental health and substance use care, and cost could be a barrier.
I mean, it can cost $250 an hour for a psychologist. If you don't have insurance, that's a big one.
And then there are also some of the practical considerations. Are you able to get transportation to your appointments? Are you able to take time off from work or caregiving responsibilities to get the supports that you need?
So I assume, like many other parts of the health system, there was a geographical divide, rural and urban.
Yes. Urban residents were slightly more likely to report unmet needs than those in rural or remote areas. And then we are seeing also that potentially in rural or remote areas that there can be also barriers to seeking care, such as perceived stigma or not wanting to reach out for care.
Those are the numbers. Sachin Latti met the people behind them as he crossed Canada, starting from his home in Vancouver, to raise money and awareness for mental illness. He says he was stunned by the amount of mental distress he uncovered. Sachin, you've done something most people listening could never try to do. You have done marathon runs across Canada, one end to the other, over 81 days. That's incredible.
Actually, I did ultra marathons. So a marathon is 42.2 kilometers. I was running at least 50K a day.
Now, the reason what fueled you to make this incredible effort, because you're very focused on mental health.
Absolutely. Originally, my plan was to run 100 kilometers a day across the country. Then quickly, within the first few days as I was running, it was clear that I had to make a pivot, because if I'm running 100 kilometers a day, I can't talk to anybody. But we had an RV that was basically a moving billboard that said mental health on it, and it basically attracted people. And we were getting stopped regularly. And as we were getting stopped, people wanted to have conversations. And it was very clear for me and the team that, okay, well, we need to actually change the entire project. So within the first week, we decided from 100 kilometers to go to 50 kilometers. That allowed me to give time and space to have conversations. So yeah, we had lots.
Keep up the good work.
Will do, man.
It's an amazing cause, man. Appreciate you.
Thanks so much. Thank you.
What I know is for me, it was the feelings, it was the traumas that I had gone through and things of that nature. But, the drugs and alcohol took that all away. So when I no longer had the drugs and alcohol to mask those emotions, I was just left with Steven again.
I lost my brother to suicide, and it was a shock, like it is for most people. And like so many young men, he felt like a burden.
What did people that you spoke to tell you that they needed to get help?
The consistent theme was that they had been struggling, that the system had failed in some ways, and they were having challenges. And a lot of the challenges from a lot of people I spoke to, a lot of them were first responders and veterans as well. In some cases, the medical treatments that they were getting weren't adequate or were not the right treatments that they were getting. With the veterans and first responders space, absolutely, there were issues as it related to the organizations that they worked for, and in terms of how they felt comfortable in sharing the issues that they were dealing with without getting either reprimanded or having their job or their roles being reduced.
That's a heavy burden to carry on top of your run. How did you feel?
Honored to have the opportunity to play a small part in helping. Now, is it draining? For sure. Considering that I'm also running from 7 to 8.5 hours each day. It was mentally draining for sure, and it took a toll, but that's why I did it.
So when the report finds that 2 in 5 report that their needs for mental health help are not being met, does that reflect what you saw?
So yeah, people weren't going to work anymore, off on stress leave. And I met a lot of people. I myself went off on stress leave.
And you're a first responder.
Yeah, I worked 18 years with the Canada Border Services Agency.
And how did that lead to your mental health struggle?
It created everything. It created the person that ended up running across the country to get some help. For me, the run across Canada was also a healing journey. It wasn't just to help other people, it was to help myself. When I first started all of this, it was because I was struggling significantly. And I was having brain fog, wasn't sleeping for months, entering into the suicidal ideation from time to time. Look, I'm 47. When I started struggling this way, I was about 42, 43. The pandemic was kicking off. I was going through a divorce. So for me, all of these things combined at the same time, and it became a perfect storm to struggle.
How urgent is it that this suffering that you saw?
Urgent. Like, people are taking their lives. How urgent can it get? Like, people are committing suicide. And people are struggling significantly. People are on the street. I hadn't seen this much homelessness ever. I ran across the entire country. And I saw it in places that you wouldn't even expect it. Small towns, population 1,100. People are homeless. So, I mean, it's urgent, for sure.
Not only is the data showing a huge unmet need, the report logs for the first time how long Canadians are waiting for mental health counseling, whether in person or virtually. Here again is Cheryl Chui to take us through the results.
That's right. We found that half of the individuals referred to mental health counseling in the community were able to get their first appointment in 30 days, whereas 1 in 10 people waited more than 4 months for their first appointment.
That's a long time. If you have a serious mental illness and it impairs your ability to work. So children and youth, how long were they waiting?
So those aged 2 to 17 waited around 24 days, while adults waited a bit longer, so about 34 days. We also monitor kind of virtual counseling visits versus in-person sessions. And perhaps not surprisingly, virtual counseling had shorter waits of 24 days compared to in-person sessions of 29 days.
That's still long. Yeah. Why are there these waits? Were you able to tease that out?
So there may not be the available programs, and where there are programs, maybe not enough spots. We're seeing a high demand for care. And so all of those factors together contribute to wait times.
What I also found striking in the data is about patients who are hospitalized for addiction and mental health treatment. But when they're done, their discharge, what happens to them? And the data shows a lot of them don't get much support.
So what we saw was when we measured this for the first time is that in 70% of patients who were hospitalized for a mental health or substance use reason saw a physician within 30 days of their discharge from the hospital. So all I'll add is that a hospitalization for mental health and substance use can occur when symptoms pose a serious risk to the patients themselves or to others. And so there ideally should be follow-up care provided to manage symptoms and prevent them from needing to come back to the hospital if possible.
Did you measure anything more other than a visit by a doctor? Or was it just a visit with a physician?
So we only looked at visits with a physician, and we know that follow-up care is provided by other mental health professionals, such as nurses, social workers, counselors. So this is something that we are continuing to work with our data partners in provinces and territories on, is how do we collect more data on the follow-up care that is happening across provinces and territories so that we can have a fuller picture.
Waiting a month for follow-up with a physician increases the risk that someone with a severe mental health illness or addiction will relapse and end up in hospital again and again, a costly cycle. That's become the focus of a pilot project. Waypoint Centre for Mental Health Care is in Penetanguishene, Ontario, 2 hours north of Toronto. The hospital was given targeted funds to see if adapting existing home care services for mental health support right after discharge boosted the odds of sustained recovery with fewer hospital admissions. And guess what? It worked. You're about to hear more from Kevin Young, Medical Director and Chief of Staff. Dr. Kevin Young, welcome.
Thanks very much. Looking forward to this conversation.
One of the problems that the CIHI report highlights is this gap following hospital care. And only 70% of those discharged from hospital were able to get a physician appointment within 30 days. That means it suggests that 30% are not getting anything. And that 30-day gap seems to be a bit of a worry, in that these are often fragile people who have just undergone treatment. So this gap is what sparked your hospital project that we're about to discuss.
That's right. We've long sort of been concerned about this problem. If somebody leaves a general hospital with a physical health ailment, they often have home care and they often have supports in order to transition them back and figure out what they need and just to help them to get back on their feet again. But the same programs did not exist for people with mental health needs. And what we found is when they left hospital, they weren't sure where to go. They weren't sure where to get help. Things sort of started to fall apart again. And so they go back to the emergency department, which would really mean that they start that entire journey over again and going through the same motions and not actually getting better.
What's the personal cost and the system cost of not having rapid and regular follow-up for these discharged patients?
The personal cost is phenomenal, because when people lose faith in the system and they don't know where to go, then they may go to less reliable sources. They may go to the internet, or they just may have untreated mental illness, which has obviously substantial impacts on quality of life and may even lead to somebody not wishing to continue with their life. We're not meeting people's needs and they keep coming back into the system. Then we're essentially paying for assessments and admissions and lots of service that's not benefiting people.
So you started this experiment, this study.
It was essentially a pilot project that we wanted to demonstrate whether what we thought would help people was in fact the case, and just to make sure that the principles behind it were sound.
Did you design it yourself, or is it based on something that you saw elsewhere in the world?
We designed it together with an organization called Bayshore, which is a home care operator. And from research that we had done from our patient groups on what they needed when they left hospital, we looked at the literature in terms of what was done, but we did not find an exact model that would replicate what was happening in the Ontario environment.
So is it first in Canada?
It's definitely the first in Ontario. We don't know of any other similar programs in Canada, but other jurisdictions in the world do things like this and do have good outcomes.
How long has the project been in place? Let's start with that.
We started the project in about June of last year, and so it's just coming up to the 1.5 year mark now.
So what's the program called and what does it offer?
So the program is called Waypoint at Home, and it offers up to 16 weeks of home care for people that were in hospital or that came to the emergency department and were at risk of coming to hospital, and essentially offers them additional supports through the home care system to help in that transition back to the community and make sure that they're successful in staying there and not needing to come back into hospital for more intensive care.
How is it different than home care for a physical issue?
So somebody may need some help with addictions counseling, or they may need help learning some life skills in order to be able to live alone or to connect with the community and to be able to know how to get the supports in the community. And so we really had to think about what are the things that people are not getting that are causing them to come back to hospital and using the emergency department repeatedly.
So it's coaching.
It's partially coaching. It's partially making sure that people develop the skills to come to appointments, to access care, to be able to shop and cook, and essentially not get back into some of the patterns of living that have led to the problems that made them come to the hospital in the first place.
So you have some preliminary data from the year and a half. How many people actually go through this 4-month program?
So to date, we've had 108 people that have been referred to the program, 97 that were eligible and that have either been through the program or are currently completing the program. And of those people, we tailored the length of the program to their needs. And so some people went through the program for 4 weeks and some went for the whole 16 weeks or something in between, but then we're able to successfully transition out of the program.
And then how do you measure if it's a success?
So before we started this project in our region, 25% of people who went to the emergency department for a mental health need came back to the emergency department at least a second time, if not a third, fourth, etc. time. After we started this program, we looked at the people that have enrolled on the program. And in our first year of service, 15% of people came back. So that was a dramatic decrease from 25% to 15%. And in our sort of now second year of the program, that number is further declined from 15% down to current number of 6.3%.
So you went from 25% returning to hospital to just over 6%. I see a smile there when you were telling me the data.
Yes, we're very proud of the data. And people don't want to come to the emergency department. They don't want to come back to hospital. They want to get the help sort of when they're living in their communities and when they're living their lives and when they're trying to create a quality of life. And so doing something that I know is having an impact is incredibly important.
Any anecdotal stories that were passed up to you on differences it made in people's lives? Or, for example, the emergency units of the 7 hospitals that feed into you, are they saying they're seeing less of these repeat patients?
Yes, there was a couple of anecdotal incidents. One was where an emergency department was reaching out to a patient because they were concerned that they used to see the patient on such a regular basis, and then they stopped seeing the patient and they were worried for that patient's health to make sure they were okay, only to find out that they were the best that they'd ever been and they weren't coming because they were on the at-home program, they were getting the services they needed, and they didn't need to come to the emergency department. And I think that speaks volumes for itself. And there's been multiple stories where people just say, nobody actually ever stopped to think about like what it was that I needed to really thrive and what was missing and why I wasn't getting sort of back on my feet. And this program has really like stopped to think about that and asked me what's important to me and asked me what I need. And people are telling us that makes a huge difference, and it's not surprising.
It gave me chills when you said that an ER actually reached out to someone to say, "We haven't seen you." That's an amazing anecdote. Let's talk about cost benefit. So you go ahead and go with how much does the program cost? How much are you saving the system?
So a program like this, the funding is about $1 million per year to support the number of patients that we're seeing. This is part of a much larger strategy that we have in order to keep people from coming back to the emergency department. And so we look at the cost savings for that entire program, which includes the at-home program, for the number of people that where we've avoided admissions and where we've avoided emerge visits. That entire initiative has saved over the last year at least $4.3 million, and probably much higher because that number was last calculated many, many months ago.
Have you presented this data anywhere, or are other hospitals hearing about it?
So we've had a lot of interest from a lot of people. So government's been interested in some of the early data, and the program actually started out with half as much funding, and then it expanded because of the success. We've also had many hospitals reach out to understand how we've done this. My understanding is that there's another Ontario Health team in the Kitchener-Waterloo region that's recently started a similar program. And in fact, right after this interview, I have a chat with another hospital who's interested. And so this is becoming something that I'm talking about on a regular basis. And I really hope that others are able to replicate what we've done here and that it's able to grow through the province. We've also been working with several of the home care agencies because we realize that we may be able to make more of an impact by taking what we've learned and being able to train and build up some capacity within some of the other agencies that are throughout the entire province to be able to roll out some of the activities that we're doing here to the much larger population.
So you are training home care workers like VON, St. Elizabeth, and other agencies to be able to be counselors for mental health? What's your hope for this?
My hope for this is twofold. The first is that others will see what we're doing and be inspired and will come up with their own versions of this, may even improve on what we're doing so that we can learn from them. And then my second hope is that policymakers and government can look at programs like this and realize that if we start to rethink the way that our system works, we can actually provide better outcomes and we can make the system sustainable.
We'll give the last word to Cheryl Chui about the future implications of this new data, the tracking over time, the feedback, and the measures of accountability for Canadians who have made it very clear mental health and addiction care is a priority.
I mean, I think this is what Canadians want to see, that the commitments that have been made are actually bearing fruit. And so this is what we're hoping our data can help to reveal, is where we're seeing some change, some improvements, although it takes time for some of the improvements to be realized and to kind of show in the data. I think that's the importance of continuing to monitor and to look at the data year over year. And so this is why CIHI, along with data partners, is trying to bring together really kind of complex information and to distill it in such a way that we can see where progress is being made and where additional work is needed.
Some notes. Sachin Latti continues his awareness campaign with a documentary and podcasts on his extraordinary run coming out next year. Waypoint will continue to track its successes in keeping patients out of hospital with mental health supports in their community. And CIHI has posted all the data from this landmark report. You can find it at CIHI.ca. Thank you for listening. We welcome your comments and suggestions. I'm Avis Favaro. Talk to you next time.